Hi, I am Michele Green. I am a DNP candidate at Maryville University and will be presenting the Quality Improvement Project of Social Emotional Health in Early Childhood Students, Play as an Intervention. I would like to extend my gratitude to the DNP committee, whose assistance was foundational to the DNP Quality Improvement Project. Dr. Boniface Stegman, my chair, has been an outstanding resource and supporter of my project from the beginning, and her guidance throughout the process was both instrumental and inspirational. I also thank Dr. Maria Snell as the second reader of the DNP Scholarly Project. She is the Director of Doctor of Nursing Programs at Maryville University, and having her feedback was valuable to the project. Additionally, my gratitude is extended to my community member at the site of the Quality Improvement Project, Sarah Klein, for lending her expertise and enthusiastic support of the project. It is estimated that more than 40% of early childhood age students have been identified as having social emotional health concerns or deficits in social emotional functioning. The identification of having social emotional function deficits can later develop into a diagnosable mental health condition. In more than half of the time an individual is diagnosed with a mental health condition, the diagnosis occurs by the age of 14, and social emotional concerns are observed as early as preschool entry. This leads to a potential for implementing early intervention techniques to enhance social emotional functioning and potentially influence later mental health concerns. Social emotional health is developed during the stage of early childhood, and the skills of social emotional health are learned from an individual's social environment. The components of social emotional health include the domains of self-regulation, ability to relate to others or empathize, resiliency, and self-awareness. These social emotional health domains are foundational for an individual's ability to function within the context of social environments. During a child's formative or early childhood years, learning occurs rapidly and with flexibility. This malleable stage of learning supports an individual's ability to grasp new social emotional health concepts and solidify social emotional health skills. When healthy social emotional skills are developed during these formative years of learning, later positive social emotional and mental health outcomes are observed throughout the individual's lifespan. An individual's experiences during their early childhood years influences their life's trajectory, and underdeveloped or poorly attained social emotional skills contributes to disruptive behaviors. When an individual exhibits disruptive behaviors within their social environment, there's also the potential for adverse effects on their own and their peers' ability to learn and integrate foundational skills, potentially creating a deficit in the attainment of skills necessary for both academic and social emotional growth. Imperatively, when provided a learning environment supportive of social emotional skills development, children proceed through their primary academic years with greater social and educational outcomes than those without any social emotional intervention. As children learn naturally through their environment using the language of play, the scholarly project aimed to use the evidence-based practice of play-based intervention within an early childhood setting to improve social emotional health outcomes. The aim was to reduce behavioral concerns in early childhood students using play-based intervention compared to the site's practices in place at the time of the Quality Improvement Project development. At the time, the system in place at the site utilized any available staff members to assist in the de-escalation of problem behaviors displayed by a dysregulated child so the student could rejoin their peers. If a child was identified for more individualized support, the site used a check-in and check-out process, which consisted of the student discussing with a staff member about how they were feeling during the check-in and check-out periods. The play-based intervention aimed to integrate social emotional support within behavioral health nursing plans and to educate site staff on the effects of using play as a tool to address behavioral concerns. In the literature review, 4 themes were identified: social emotional underdevelopment, risks of disruptive behaviors, therapeutic play, and improved social emotional outcomes. Social emotional underdevelopment was linked to growing up in impoverished households, which increased the risk of multiple barriers that influence adequate social emotional development opportunities, such as lack of access to health resources. And children living in poverty also may not have access to quality school programs with the resources to intervene in social emotional health concerns. Also, nearly 30% of preschool-aged children living in poverty exhibit disruptive behaviors that hinder healthy social emotional development. Social emotional underdevelopment results in disruptive behaviors which later become ingrained as part of the child's character and influence later decision making. Secondary to ingrained disruptive behaviors, children may feel more comfortable aligning themselves with peers that they can relate to, such as those who also have social emotional deficits. Additionally, disruptive behaviors within the learning environment strain teacher and student relationships and negatively impact teacher perception of a disruptive student's ability to learn, potentially affecting the student's academic outcomes. Therapeutic play allows for children to safely learn about themselves and how they want to interact in a healthy manner with others, with the play environment serving as a representation of larger society. Therapeutic play also allows the provider to teach pro-social skills for social emotional development and to redirect disruptive behaviors in the moment. Across the literature, the use of therapeutic play to address problem behaviors in students resulted in disruptive behaviors being reduced and an increase in on-task behaviors. The theoretical framework selected was Newman's systems model, which aims to maintain or restore the state of wellness through 6 concepts: client systems, variables, environment, stressors, health, and nursing interventions. Newman's systems model focuses on an individual or group as being engaged in a consistent and energetic exchange within the environment as a client. Each client has lines of defense surrounding the client's core being and energy. Dependent on the level of development, the lines of defense affects how the client responds to environmental stressors. When a child experiences social emotional underdevelopment, interventions to enhance the child's lines of defense prevent loss of well-being within the client. In Newman's systems model, physiological, psychological, sociocultural, developmental, and spiritual variables influence how a person interacts with their environment as a unique individual. The systems model also views environmental factors made of internal, external, and created environments as an influence on the client. Children with underdeveloped social emotional skills may rely on learned disruptive behaviors to create a more comfortable environment, and therefore, viewing the disruptive child as a unique individual responding to variables and their environment assists in maintaining positive regard for the child when delivering play-based intervention. Stressors may also affect the child's response to their internal or external environment. When using play-based interventions, staff working with the child can identify stressors to direct treatment and goal-setting decisions. In the systems model, health is considered to exist along a continuum from wellness to the extreme of death. The client's core energy moves along the health continuum proportionate to the amount of energy being used and regenerated. The state of health is individualized with stressors, the use of coping skills, the created environment, or lines of defense which affect placement along the health continuum. Utilizing play-based techniques to impart new coping and social emotional health skills can assist a child in maintaining a state of functional well-being. Nursing interventions within the systems model are specified to client needs, whether primary, secondary, or tertiary, with the nurse assisting the client to achieve an optimal state of wellness along the health continuum. Reinforcing social emotional development strengthens the client's ability to adapt or respond to changes within the environment in a healthy manner. A descriptive, exploratory design was utilized to conduct a retrospective chart review. Participants were not engaged, and no patient information was abstracted from the charts. The study used a pre and post implementation comparison of behavioral intervention reports used by the site to observe and rank the social emotional health domains of physical aggression, verbal aggression, off-task behaviors, and the number of crisis team calls placed in response to disruptive behavior. The behavioral intervention reports were in use at the site prior to the quality improvement project, ranking behaviors on an ascending scale of 1 to 4 for level of concern. By measuring pre and post intervention rankings on the behavioral intervention reports, a student's progress could be quantified based on the evaluator's observations of behavior over time. This is the list of inclusion criteria for the retrospective chart review. Participants had to be enrolled as a general education student at the Early Childhood Center at the time of the intervention, had to have been identified and approved by site administration to receive behavioral intervention with documentation reflecting the rationale for referral. Participants additionally had to have participated in play-based intervention with documented ratings of physical aggression, verbal aggression, off-task behaviors, and documentation of the number of crisis team calls placed to intervene when a student exhibited disruptive behaviors. Finally, all charts considered for review had to have documentation of the problem behaviors exhibited both before and after intervention at the site. All genders and races were considered for inclusion. This is the list of exclusion criteria for the retrospective chart review. Any behavioral intervention report within these parameters was not considered for retrospective chart review. Charts with individuals considered as receiving some form of special education, educational accommodations, a documented disability, or requiring language interpretive services were not considered for the retrospective chart review. A total of 10 charts from 5 participants qualified for the retrospective chart review. Despite best efforts, a smaller than expected sample size was collected for the retrospective chart review. The range of data from 1 to 4 within the domains of behavioral indicators limited potential variability. The study was designed to be implemented across a larger population of participants for sampling. Despite the intentionality of the design, the small sample size was considered statistically insignificant with insufficient power, and the data analysis was limited to discussion of descriptive statistics. During the retrospective chart review, the measured social emotional health domains were compared using ordinal and nominal data from pre and post intervention periods. Ordinal data is used in descriptive statistics to represent data characteristics and to discuss comparisons of change across data sets. While mean, median, or mode measures may be applied with data frequency distributions in descriptive statistics, the mean or average is frequently used to compare data sets. And the study described results using the average change across each of the social emotional health domains. The domains of appropriateness across physical aggression, verbal aggression, and off-task behaviors were categorized with ordinal data. Each domain was ranked as 1 being appropriate, 2 mostly appropriate, 3 inappropriate, and 4 mostly inappropriate. The number of crisis team calls placed for each participant pre and post intervention were signified by ordinal data. 6 weeks before participation in play-based intervention, Student behavioral domains were reported on the site's behavioral intervention reports. 6 weeks after the conclusion of the play-based intervention program, educational staff completed an additional report on student behaviors using the behavioral intervention reports. The data from the behavioral intervention reports demonstrated that there was a reduction in the mean rating across the social-emotional domains assessed. The level of concern ranked using an ascending scale from 1 to 4 declined from a mean of 3.2 to 2.4 for physical aggression, from 3.4 to 2.6 for verbal aggression, and the domain of off-task behaviors declined from 3.8 to 2.8. The number of crisis team calls for each participant also declined from a pre-intervention mean of 10.4 to 7.2 following participation in play-based intervention. While the analyzed data was not considered statistically significant, the descriptive data demonstrated an improvement in all social-emotional health domains measured following participation in play-based intervention. There were limitations within the quality improvement project that prevented a larger sample size. The research occurred at a time when students and educators were returning to school full-time following the COVID-19 pandemic. As such, heightened levels of concern about physical health and safety while navigating the quality improvement project when health and safety policies were frequently changing impacted levels of educator stress and subsequently reporting on intervention outcomes. Additionally, there were both staff and student absences in the week leading up to a planned holiday break during which the quality improvement project was implemented, either due to planned absences or mandatory periods of isolation following suspected or diagnosed communicable illness. The increased rate of absences limited educator and student participation in the play-based intervention and potentially affected outcomes reporting. Due to the small sample size, generalizability was challenging to ascertain, and the internal validity of results from this particular study and potential applicability to other populations could not be proven. Had the research been conducted across multiple sites with a greater number of participants with comparable results to those in this study, a conclusion regarding the connection between play-based intervention and improved social emotional health within a larger population could have been more accurately determined. There was alignment between the quality improvement project expected outcomes and evidence-based outcomes within the literature. The expected outcomes from the quality improvement project were decreased problem behaviors and reduction in the number of crisis team calls made for the students. The quality improvement project showed there was an observable decrease in the behavioral domains of physical aggression, verbal aggression, and off-task behaviors for students participating in play-based intervention at the site. The literature widely demonstrates improved social-emotional behaviors following participation in play therapy methods. To improve on statistical significance and generalizability, play-based intervention could be delivered across several early childhood education sites. Incentives for educators for completing behavioral data reporting could be provided, and the program could be expanded to include participants in which caregivers identified a concern about behavior outside of the academic environment. While the sample size was considered statistically insignificant, nonetheless, the results from the study were encouraging. To improve on health outcomes, nurses working with early childhood age students can integrate the evidence-based practice of play-based intervention techniques when social-emotional health deficits are suspected or identified within the pediatric population. The DMP's scholarly project demonstrated improvements in the safety of child participants and potentially their lateral peers through reduction in aggressive behaviors. Play-based intervention can be applied across pediatric care settings to intervene in behavioral safety concerns without the requirements or potential risks of pharmacological treatment. Equipping nurses to provide a play-based intervention enhances physical and emotional safety and improves pro-social behaviors with far-reaching effects across the health continuum. Social emotional health is developed during early childhood, with social emotional attainment level linked to later health effects. The DMP scholarly project demonstrated an improvement in social emotional health domains through the use of play-based intervention in early childhood students. Using play-based interventions to enhance social emotional development within early childhood ingrains pro-social skills through a child's natural language of play. Through play-based intervention practices, nurses can have an early and direct impact on a child's trajectory of social and emotional health outcomes. From the conclusions of the DMP Scholarly Project, nursing delivery of play-based intervention to address social emotional health concerns across pediatric healthcare delivery settings is recommended. Thank you for your time and attention. I will now open the floor to your questions with references slides to follow.